Hi, everyone. Welcome to another episode of Ask the Egg Whisperer. I'm Dr. Aimee, and I'm so glad you're here. Every week, I start by answering your thoughtful questions that you've submitted ahead of time, and then I switch over to take the questions that you ask live. The questions we have today cover so much of the fertility journey, from what to expect when using medications with IUI, to how many embryos you may want if you're planning for more than one child, to whether an endometrioma should be removed before moving on to IVF. We'll also talk about what supplements and treatment strategies might help when you've been trying to conceive for a long time, and even whether it ever makes sense to retest embryos that were found to be abnormal. So let's dive right in. The first question comes from Ayla, 47, from Houston, Texas, and this is her question. I'm 47, trying to conceive for the last 10 years. I've had 3 miscarriages and 3 unsuccessful IVF cycles. My AMH is 0.35, LH34, FSH11, and TSH is 0.8. What supplements and what treatment would you recommend for me? Also, I have 2 frozen embryos from 2022, and PGT testing show that they're abnormal. Would you suggest retesting them? So, Ayla, I am what people call a hope dealer. So I always believe in prioritizing things that patients want. Meaning, if you feel like you have hope in your heart, well, I'm going to feel that too. So even if the likelihood of success is close to 0, I'm going to try and give you every chance that I can, even though chances are low. So we have to ask ourselves, truly, what are the chances at 47 that a woman can have a healthy pregnancy? Well, unfortunately, it is close to 0. Even if you have healthy fertility levels, and your AMH level is certainly telling us that you still have eggs that you could retrieve. But the thing is that I can't wave a magic wand and turn 47-year-old eggs into healthy eggs, but I don't think that there's any harm in trying. So when I tell a patient who's, let's say, 47 years old, I said, listen, let's give it 6 months. Let's see what we can do. And then if things don't work out the way that we wanted them to, let's pivot and talk about other options like donor eggs. The kinds of supplements that I tell patients to take include probably things that you're already doing, like CoQ10, prenatal vitamins, OVA NAD+, vitamin D, and fish oil, not because they reverse egg aging, but they can potentially support egg quality, and they also support your overall health. As far as the embryos that tested abnormal, the likelihood that they could turn into a healthy pregnancy is pretty low. It's probably around 2%. The technology that we're talking about, for those of you who don't know, is called PGT-A. The A stands for aneuploidy, but I call it PGT ambiguous because it's not as accurate as people think. So that is something that you can do, is just try with the embryos that tested abnormal. I think retesting them probably isn't the best use of your resources because it's highly likely that they'll still come back abnormal. But depending on what the abnormalities are, you might want to consider just transferring and seeing if they will work, understanding what the worst case scenarios will be. So I do abnormal embryo transfers for patients here in my practice, and I have had live births from them, from embryos that were solid abnormals, like a missing chromosome or an extra chromosome. And what I tell my patients to do is something called a post-PGT consult with a genetic counselor. And you have to ask them and say, what is the worst case scenario if I try and transfer this embryo? Is there a chance it could work and turn into a live birth? And hear from someone else. And if you still feel like it's worth it for you to have that experience, then I would say go for it. The problem with doing that, though, is there's always a chance for a clinical pregnancy loss. And then having to go through a DNC, and then, that's basically 3 months of your life that you can never get back. But if that's an experience that you want to have, that's something that doctors like me will support you with. So the next question comes from Lori, 38, in Northern California. And here is her question. I'm strongly considering IUI and was told it can take several months of trying. I want to be prepared for how my body may feel or the common side effects from the medication protocol that goes along with IUI, like letrozole, progesterone, and the trigger shot. Which has fewer side effects, progesterone injection or suppository? Can you give some insight into these medications, potential side effects, and how long they may last? Also, any special sauce suggestions are welcome. Okay, Lori, I love that you're asking about my special sauce, but my special sauce, there is a special sauce, but it includes, number 1, making sure that your tushy has been checked. You're probably like, what are you talking about? Why is she talking about someone's tushy? Well, I'm talking about the tushy method. So before you go into your IUI cycle, make sure your tubes have been checked, your uterus has been checked, there's no signs of adenomyosis or big fibroids that need to be removed, sperm has been checked. It sounds like you've had your hormones checked, I imagine. And then your genetics. So make sure you and your partner are genetically compatible and you've done carrier screening before you try IUI. If you meet all the criteria and everything is all clear for IUI to happen, then talk to your doctor about what your chances are at your age with your levels to have an IUI successful pregnancy. I think people are surprised when I tell them what the numbers are, but it's usually less than 20% that we can get pregnant with IUI at 38, but it's not zero. I don't think there's anything wrong with doing an IUI at 38 years old. Nothing wrong at all. But I also don't want you to be wasting precious time thinking that if you do enough IUIs, eventually it will work, because sometimes it just doesn't, because we're not able to recruit enough eggs to have the healthy egg ovulate. And even when you have a healthy egg ovulate, there's so many steps that have to occur in order for you to have a healthy pregnancy. The egg and sperm have to meet in the tube. The embryo has to grow and travel down the fallopian tube and land in the uterus. It can get lost and then it has to stick and grow. So you can see how hard it is to get pregnant with an IUI, but it's not impossible. I mean, people get pregnant all the time naturally and with IUI at 38. So to talk about the questions you asked as far as the side effects. So side effects of letrozole: hot flashes, headaches, and lower leg cramps. It almost feels like you have cramps both legs and it's kind of irritating. But the good news is that letrozole is out of your system within 2 days of taking the last pill. So that's good. So if you get a headache, I always tell my patients not to tough it out and to take pain meds like Motrin, Tylenol, and also don't stop drinking that coffee. I know there's so many messages out there. A lot of them are mixed messages about coffee hurting your fertility. But trust me, coffee can help with the headaches that you get. So you don't want to start fertility medication and then also stop coffee at the same time. When it comes to progesterone, it's kind of a shove and go mentality. And I'm talking about the suppositories. And when you're placing something vaginally, that can cause vaginal discharge. And that can be kind of icky. But there's less mood side effects if you place it vaginally than take it orally. When you take progesterone when you can take progesterone orally, it can make you feel a little drowsy, a little moodier than if you were to place it vaginally. This is a true story. I'm trying to see if I can tell this joke correctly. I had a patient and I took a picture of her bottle and her bottle said, place progesterone vaginally by mouth. So her husband called me and he said, this true story. And they promised me I could share the story for the rest of my life. Husband called and he said, does that mean that I have to place it? Yeah, I know. It's funny. Or at least I thought it was funny. So you can use it both ways, orally or vaginally. It's equally effective. Either way you do it. It just depends on which side effects. And you can always go back and forth. You can place it vaginally. If you don't like the discharge, then you can take it orally. And there are patients who actually prefer progesterone and oil shots. Maybe about 2% of my patients are like, I don't want to, I would much rather stick a needle in my booty than to place anything vaginally. And I just don't like taking something orally because it makes me too sleepy. So progesterone oil is also an option, but they hurt like heck. I've actually tried one myself and I had like pain down my leg for a couple of days afterwards. So progesterone shots are not to be taken lightly. And then my special sauce would be, taking supplements, taking really good care of yourself. I already mentioned the supplements with the last question that I answered, but things like CoQ10, resveratrol, OVA NAD+, I think those can all help support your egg quality. And then just making sure that you're getting good sleep, you're exercising, you're hydrating, you're as zen as possible, and you're floating through life, and that you're not attaching emotions to the outcome, understanding that the chances are low, but you still want to give it a chance. And then if it doesn't work, talk to your doctor potentially about an IVF plan if IVF is acceptable to you. So next question comes from Daniela. Daniela's 36 from San Francisco, and this is her question. How many good embryos would you say you need to have 2 pregnancies? I did 1 round of IVF, and I have 3 good embryos. I'm planning to do a second round before transferring because I want 2 kids. So I do fortune telling all the time. I call it fertility fortune telling. And I wish that I was better than a fortune teller. I think maybe I am a little bit. But that's the problem with fertility. Is there are no guarantees. We can predict things for patients, but you never know what's going to happen. So I love that you're actually thinking about preserving more embryos. So I'm just going to say, Daniela, thumbs up, smart planning. On average, 2 to 3 good embryos lead to 1 live birth. So if you're hoping for 2 kids, another round is great. Aiming for 5 to 6 embryos is a great strategy. You want to stock up, but not so many that you potentially could have like ethical or personal issues with letting go of your embryos. So one of the conversations I have with my patients is around, what are you going to do with your leftover embryos? You really want to answer that question from the beginning, because if you're someone that's not going to be able to discard these precious cells, you don't want to donate them to research or another family, you might want to rethink making excess embryos, because you can always freeze eggs rather than making embryos for that second cycle, and then see if you really need to make embryos from them. So that's just something that I bring up. Not that you need to do it, but I just share that little tip because sometimes people don't realize that maybe they just freeze eggs if they don't want to have extra unused embryos. So the next question comes from Jenny. She's 35 in Utah, and she asked this question. On my first egg retrieval, I had 7 to 8 follicles growing on my left side. My right side wasn't responding, and I had decreased ovarian reserve. My AMH is 0.8, but only 2 eggs were retrieved. Does that mean I have empty follicle syndrome? Or would another protocol increase my chances of retrieving more eggs next round? I read dual trigger shots can help, but my doctor said no and is instead putting me on an estrogen priming cycle. So Jenny, I'll tell you that empty follicle syndrome is extremely rare. It's like seeing Bigfoot. I mean, that's how rare it is. There are people that say they've seen Bigfoot, but I've gone over 18 years. I started fertility. My fertility fellowship started in 2005. So we're talking like 20 years now. I haven't seen a single case of empty follicle syndrome. So what likely happened is that the eggs just didn't all release and they weren't mature enough to float to the middle of the follicles, so that when your doctor went to do the egg retrieval, they weren't able to remove the eggs. So you probably had eggs in there, or some of them could have been cysts. That's another possibility. So in a case like this, the things that I think about include really looking at the trigger shot instructions and the trigger shot protocol that you used. If you triggered at, let's say, 35 hours, maybe make sure that you trigger at 36 hours. I think a dual trigger is a great idea. Also, look at the size of the follicles at trigger time. If, let's say, they were all 18 millimeters and below, maybe aim for 20 to 22. That's sometimes a good strategy to get more mature eggs the next time. So talk to your doctor about all of those things. HGH could be a supplement that might also help egg maturity. So I call it a supplement because it doesn't really increase the size of the follicles or make the eggs grow faster or anything like that. It's just something that may help in some cases with egg maturity. So you might want to try that. So the next question comes from Melly, age 34 in Northern California. I'm going to read it now. I'm thinking of doing a second round of IVF. I had my first egg retrieval a couple months ago, 8 blasts, but only 1 normal tested embryo. I have signs of endometriosis and PCOS and a history of polyps. My sonogram was normal. So Melly, 8 blasts. There are scientific reasons to be super hopeful that your next cycle could be even better. So having 1 out of 8 at 34, I can only imagine how disappointing that was. But the first thing that I would do is really look at the genetic abnormalities in the embryos and make sure that your clinic unmasks mosaic results and look at them really carefully, because sometimes an embryo could be called abnormal, but it's really not. And what I'm talking about is embryos that are described as chaotic or segmental, also low mosaic, high mosaic. So sometimes patients are led to believe that those embryos are actually abnormal when they're really not. So I would avoid discarding any of the embryos that have been described as abnormal until you've done a post-PGT consult. So ask your doctor for who you should contact to schedule a post-PGT phone consult with a genetic counselor to review the abnormalities of your embryos before you discard them. So as far as what you can do to try and get more embryos the next time, you mentioned that you have endometriosis. Endometriosis can cause eggs of a young woman to act older. Okay. It can also impact and impair implantation rates. So this may be a good idea, a good time, since you have so many eggs, to consider doing a laparoscopic excision of endometriosis, because that may not hurt your implantation rate and it may improve that didn't come out right. Let me say that again. It may actually improve your implantation rate, and it might also help your euploid rate. And it also, get this, help you get pregnant naturally. So if endometriosis has been the barrier this whole time, because that might be what you learned from this IVF cycle, there are plenty of great stories that I can share, not that I can share, but that I have experienced in my practice, where patients go ahead and do IVF, and then we learn that maybe the endometriosis was playing a bigger role than we actually thought. Then they go do a laparoscopic procedure, and then they get pregnant naturally. So that might be something that you want to consider doing, and make sure that you see a MIGS surgeon. MIGS stands for minimally invasive gynecologic surgeon. They're doctors like me in that they went to baby delivering school. So they're all OBGYNs. And I went to baby making school, and they went to removing endometriosis school. So they're experts in removing endometriosis in a way that's safe. I consider them fertility restorative surgeons. So you might want to consider seeing someone like that before your next cycle to improve your chances of getting more endo. But you're doing all the right things. You're on all the right supplements. If you're not taking an NAD booster, you might want to start that as well. So the next question comes from Rav, 36 from Manteca, and here's the question. If an endometrioma is present, I get this question all the time from my patients also, in one ovary, and every time the dominant follicle is coming from that ovary, does it impact the results of the natural or IUI pregnancy? Would you advise removing it before moving on to IVF for a better outcome? My AMH is 1.7. I'm 36 with a good lining. So far, I'm hearing only good things. Everything that you're sharing with me sounds really positive. You're 36, you have a healthy AMH, and it seems like there's one small, I'm thinking that it's small, otherwise you would have told me that it was large, endometrioma in your ovary. So this is how I think about endometriomas. They're like uninvited house guests. Sometimes they cause trouble when they're uninvited. I don't really have no one comes to my house. They all know that I'm working the whole time. I'm no fun. But sometimes they just eat the snacks. So you just don't know, is this endometrioma really going to cause a problem, or is everything going to be just fine? Typically, what we recommend for fertility patients is to try IVF first before removing the endometrioma. And the reason is if you remove the endometrioma, it can actually decrease the egg count, and it can impact your ovarian reserve and AMH. So before maybe you do a transfer, you can consider removing the endometrioma. But if it's small, not painful, not blocking access, then typically we'll leave it alone because of the things that I mentioned as far as what surgery can do. If it's large, painful, or in the way during IVF, then removal might help. For natural conception or IUI, eggs from that ovary that have the endometrioma on it can still be perfectly healthy. So no, surgery is not necessarily the initial step. And a patient like you who, let's say, is not ready to move on to IVF, I would consider ovulation. It's called ovulation induction, but I call it ovulation augmentation, because what we're trying to do is maybe increase the number of eggs you're ovulating to increase the chances that, you'll have one healthy pregnancy. Along with that comes a chance of twins, but it's pretty low, around 5 to 8% at most. But you've probably heard me say this many times over the years, that endometriosis is a fertility threatening condition. So any woman who has endometriosis, I think, should be having a discussion about fertility preservation, especially if you want 2 kids. So freezing eggs or embryos now, even before you start, trying naturally, I think is a really good idea so that you can preserve your younger eggs now because of endometriosis and what it can do. And it can potentially get worse over time as well. The next question comes from Sophia in Michigan, age 32. I went to University of Michigan. Hi, Sophia. Can you please talk about why euploid FETs fail? So I'm just going to define some of these terms. Euploid means genetically screened embryo that came back with chromosomally normal results. A FET is a frozen embryo transfer. So we freeze embryos through IVF, we bank them, and we can genetically screen them. My first round of IVF produced 2 euploid embryos, and the first resulted in a miscarriage at 8 weeks. I'm scared to transfer the next one. How can I advocate myself to achieve success in our second round? So the first thing is, even after one miscarriage, a lot of doctors say, oh, it happened once. It's just bad luck. It could be anything, nothing else to do. We'll just transfer again. I would say most doctors like me are pretty thoughtful about what we do. So the first thing that I would do is rule out antiphospholipid antibody syndrome to see if potentially taking a blood thinner like Lovenox would prevent a future miscarriage. The other thing I do is rule out endometritis, silent endometriosis, and I really want to make sure that we're not missing a diagnosis of adenomyosis, and that's inflammation on the walls of the uterus. And if that's present, we would want to treat it. There are other things that you can look at, like immune factors as well, or you can ask your doctor for an immune protocol. And then even if you've had a cavity evaluation before this transfer, I would still do another one after a miscarriage just to make sure that there isn't any retained pregnancy tissue, or if you had a DNC, that there isn't any scar tissue. So basically, to advocate for yourself, what you want to do is ask about a uterine evaluation, immune or clotting workups, and supportive medication. If you didn't take aspirin already, aspirin. If you are positive for antiphospholipid antibody syndrome or any of the clotting things that your doctor will rule out for you, Lovenox, and sometimes even a drug like Neupogen. And here's the good news. Even if you've had one failed euploid transfer, it does not mean the next one will not work. But obviously, like emotionally, it's really hard because you're going to have the memory of the experience you had from the first. So of course, you're going to be scared that the second one, the same thing is going to happen. But I feel like if you did all these extra tests and you go into your next transfer feeling like you did everything that's in your control to give yourself the best chances, you'll be more assured and less afraid. So remember I said PGT is PGT ambiguous? Well, the reason why I say that is so often people think that they have this perfect embryo and it's going to work the first time. And of course, you're not going to have a miscarriage. But there are other genetic reasons why an embryo miscarries. There are genes in the embryo that we just aren't able to test for. You can also miss small chromosomal abnormalities when you do PGT because the platform can only pick up genetic abnormalities that are of a certain size and larger. Anything smaller, it can't detect it. So I believe in your chances. I think you have an excellent chance of your next transfer working. And I think looking at how many embryos you have and the family size that you want, it may not be a bad idea to consider doing another round of IVF to preserve more embryos before your next transfer. So that's almost it for today for our Ask the Egg Whisperer. We got so many great questions and I'm so appreciative to all of you who send them in. So thank you for spending this time with me. I'm going to go ahead and answer your live questions. But before I do that, I just want to remind you, if you have a question that you want me to answer, you just go to asktheeggwhisperer.com, submit your question, and then I will answer it. So I'm going to go through, I'm going to start from the beginning. And I saw a few questions coming in, and let's get to them. So here's the question. Hi, doctor. What is the rate for success for a 42-year-old having an egg donor? That's a great question. So the success rates, I don't know what I just said. The success rates are great, but they're not 100%. So I still think it's important to do all the things that we would do to prepare for an embryo transfer. And also look at sperm and make sure sperm is really healthy before you create embryos with donor eggs. Success rates are, over 70%, especially when you're using a proven donor. You go into it feeling really confident that you're going to have healthy embryos. Even frozen eggs work really, really well. So when I guide patients when it comes to egg donation, I ask them to get at least double-digit eggs if they're using frozen eggs, or pick a donor that has a history of previous success, or at least have an AMH level that's over 2.0. I think that using an egg donor is a great option for patients who are open to that. Next question. I'm 45, AMH is 2.2. I know my chances are low. I know I'm homozygous mutation for PI1 from DNA tests, but not from health issues. Should I be taking anything extra for this? Never tried to conceive before last month. Well, Becca, I wish you all the best. I think if there's anyone out there who can get pregnant at 45, it's you. So you have a healthy ovarian reserve, which is amazing and awesome. We still have 45-year-old eggs, so I would just plug to take, egg qualities or egg supporting supplements. And I don't think that there's anything else that you need to take for a PAI1, I call it PI1, being positive for that. It's actually quite common. ASRM and American College of OB/GYN does not recommend taking blood thinners like Lovenox for that unless you've had a personal history of, clots or anything like that. But I would say that an aspirin a day will keep the clots away, I think, for the mutation that you have. So let's see. I think there were a couple more questions today. Let me scroll through. Here we go. I read mixed reviews on IUI with medication and unmedicated IUI. Do you feel like medicated is significantly better? I'm nervous about the Avidril and letrozole. So I would take it in small steps. So for a patient who is nervous about the medications, I say, let's not do them. Let's just start with an LH timed IUI. So that means timing your IUI based on when you're ovulating. Okay, so you'll come in for ultrasounds, we'll take a look, I might draw your blood and pinpoint exactly when you're ovulating, so that's when I'll do the IUI. If that doesn't work, next cycle. If you're ready for it, try the trigger shot. That helps time the IUI. It's not required though. You're still going to ovulate if you're ovulatory, but that gives you the experience of the shot. Trigger sounds really triggering. I wish it was called something else, like the egg maturing shot or the egg releasing shot. But I guess the word trigger is a lot shorter of a word. It's a tiny needle. If you can pluck your eyebrows, you can do the trigger shot. It's just scan of your tummy. It can make you feel hormonal because it is HCG hormone, because HCG is long lasting versus LH hormone, which rises when we ovulate. So we use HCG instead of LH for that reason. And LH and HCG are very similar molecules. So that's why we use them basically interchangeably. And that's why HCG can work to induce ovulation. But it can make some patients nauseous and symptomatic. So I just don't take these medications lightly. And so if you're someone who's concerned, I think it's important to tell your doctor and do things in steps. Then maybe the next cycle, if you tolerated the Avidril, okay, maybe add in a lower dose letrozole than maybe your doctor would have started with. So I usually start, depending on the patient, if the ovarian reserve is really high, I'll start at 2 pills per night for 5 nights. If ovarian reserve is average, maybe I'll do 2 to 3. If it's really low, I'll go up to, let's say, 4. Not low, but, or depending on your age and the number of follicles, that's how I decide. But you can always say, look, I want to start off with 1 pill per night for 5 nights. And if that doesn't work, go up to 2. So don't feel like you have to commit to the full dose of the medications, and you don't have to finish them. So if you take the pill and you're like, there's no way I can do this again, then you stop it. And there are other drugs that might feel better. Like there's some patients who don't tolerate the fertility pills, but they actually tolerate the low dose injections better. And so we can use a low dose fertility shot like Gonal F or Follistim or Menopur to help you ovulate more than 1 egg to give you a better chance if that's what your doctor thinks that you need. So this next question is, I was told I can only do endosurgery after egg retrieval and not before. Is this normal? And so, I would say that is mostly the recommendation that MIG surgeons have, and I'll tell you why. This is why. So IVF meds can stimulate endometriosis to grow. No doubt about it. When your estrogen levels rise, their endometriosis gets really excited and it grows. Okay. How much it's going to grow, we don't know. It just is patient dependent. One of the things I do when I do IVF on patients is I give them letrozole during their cycle to prevent the rise in estrogen. So it dampens it so that I don't have to worry so much that I'm worsening your endometriosis. So that's why endometriosis surgeons say, do all your IVF first, then I'll do a cleanup of your endometriosis and improve your chances for transfer. However, like one of the questions we got today, I shared with you that what I typically do is I'll do the first cycle. And if we didn't get the outcome that we expected or wanted, then we say, you know what, this endometriosis is actually really impacting our egg quality. Let's do laparoscopy before our next cycle. But it's really up to you. You can certainly choose to do endometriosis surgery first if you feel that that's really important and something that you want to do. I don't think a MIG surgeon would say no to that. I think that they would still support you. So next question is, hi doctor, my AMH at 35 years old was 0.09. Doctor told me to try insemination. I tried 3 times, didn't work. Now I'm 39. My AMH is now 0.069. What will it be? What would give me the best chance to get pregnant? Okay, so here are some of the things that I do for my patients. These aren't standard things that other doctors do for their patients. So in a case like that, I would talk to you about using a repurposed drug called rapamycin. It's an anti-aging drug. No joke, I am on it. It can increase longevity maybe by 10 to 15% in humans. We'll see if I'm around at 120 years old. It can also prevent, or not necessarily prevent, but delay menopause. But one of the cool side effects, it's a cool one. Are you ready for this? It can increase AMH in a lot of women. And so there was a study done out of Columbia University called the Vibrant Study. Look it up. And what they found, this was one of their findings, and I'm not sure that you can really say this because they didn't follow women for 5 years, but they said that it may delay menopause for 5 years. So when I read the findings and I looked up some other studies on IVF patients, I said, holy smokes, this could be something that I could use in a patient just like you, who's 39 with a low AMH, to see if I can increase your AMH, increase the number of eggs. And there have been published studies, and one of them is going to be mine very soon, showing that it can also improve egg quality. So that might be something that you do. The other procedure that I perform for patients in cases like yours is called ovarian PRP. And I also want you to consider taking NAD+, resveratrol, CoQ10. So these are all supplements that could potentially help support your egg quality. You could still be a candidate for IVF if that's something that you feel like you want to try, but you could still get pregnant naturally as long as your tubes are open and sperm is good naturally. And if typically my general rule for doing IVF on someone with a low AMH is I think it's worthwhile if you can get 3 mature eggs. If it's less than 3, you might be at that point where trying naturally or IUI, the chances are the same as IVF. But I've had success stories, many with patients who have just 1 follicle, 1 egg, and 1 healthy pregnancy. So I don't want you to think that the chances are 0 because they are not until they are. So next question is, what is your take on segmental aneuploid embryos? So when you look at your PGTA report, there are a number of different types of results you can get. One of them is segmental. And how do you know if your embryo is segmental? You got to look for this letter. There's 2 letters, P and Q. So either a small piece of the chromosome area is missing on an arm of a chromosome, or a small amount is, did I say missing? Or there's a duplication. So it's either missing or there's a little bit of extra, a little something, something more, or a little bit is missing. And so there's some data, not some, there's a lot of data, published studies showing that segmentals could actually turn into healthy embryos. They might be a form of mosaicism. I'm not talking about mosaic segmentals because those are mosaic, but even truly segmentals could result in healthy babies. So how do you know? Well, you meet with a fertility geneticist and they'll tell you how much of the DNA is missing or duplicated. And they'll tell you if there's actually a syndrome associated with it. So basically you want to ask the fertility genetic counselor, what is the worst case scenario if I transfer this embryo? If it's one of those things where they say, well, yeah, if we transfer this embryo and it does take, the baby will have severe developmental delays, and other abnormalities, you may want to rethink transferring a segmental. But sometimes they say, oh, yeah, there's no reports of any baby born with this abnormality. It's either going to take or not take. And if it takes, it's most likely to be a healthy pregnancy. Well, you might want to consider transferring it. So let's see here. Next question. I'm 35, about to start an IVF cycle after 2 unsuccessful IUIs this summer. I was put on levothyroxine 25, then up to 75, and now 50 because my thyroid is oversuppressed now. How could this impact IVF? I don't really think it impacts IVF. I mean, the good news is that it sounds like your doctors are paying careful and close attention to your thyroid function. And for me, when it comes to thyroid function, what's the time when it's really important to make sure everything's perfect is around transfer time, because that's why it's important for us to pay attention to it, because the fetus's thyroid doesn't start making thyroid hormone until the 2nd trimester. So it relies on maternal thyroid production. So that's why if someone is hypothyroid, making sure that they are making enough thyroid through either their own thyroid gland or through support is really important. So I would say proceed as planned. Don't let your thyroid, what's going on with your thyroid, impact your plans for IVF, but definitely talk to your doctor and make sure that they agree as well. Next question. I got 15 eggs retrieved, 4 made it to blastocyst, day 5. I'm waiting for day 6 results. Will PGT hurt the result? I'm 36 with endometrioma, 3.5 centimeter on the left ovary. Will PGT hurt the results? Will PGT, I think what you're asking is, will PGT hurt your embryos and maybe be too invasive? So the answer really is in how good quality of your embryos that you have. So if you have really good quality embryos, doing a biopsy won't hurt. But one of the things that I've seen in some clinics is they're biopsying embryos that are extremely poor quality. And I worry about those embryos being harmed and damaged. So I will not biopsy an embryo unless it's safe for my embryologist to do it. And so we have parameters, and they all know that if the embryo doesn't look safe to biopsy, meaning there aren't enough cells in the shell of the embryo, we're not just going to biopsy it to biopsy it. So if the inner cell mass, which is the first letter that an embryo gets, is a really good letter, but the cells in the shell aren't really strong, then we're going to freeze the embryo without testing. So that's a really good question. PGT could potentially harm an embryo. PGT is the genetic analysis, but the process of running the analysis involves removing cells from the shell of the embryo and sending that off for testing. Okay, next question. Second retrieval resulted in less follicles. Same protocol added letrozole and omnitrope. Last time 23 and now 16. 8 fertilized, waiting on day 7 report. I don't see another question with that, but what I would say is there is cycle to cycle variability. Follicles are like waves in the ocean. Some waves will be a little bit bigger than others. You never know how large the wave is until you start your medications. So the baseline follicle count will tell you, but it sounds like you're a very good prognosis patient. So I'm glad to hear your results. Next question. Does high estradiol levels greater than 6,000 on day of trigger affect egg quality? I personally don't think so, because if you look at egg donor data, I mean, egg donors typically will have estradiol levels sometimes over 6,000. We don't like to do that, but sometimes it happens inevitably. And when that happens, they still make really beautiful, healthy embryos. So I don't think high estrogen levels will quote unquote fry your eggs. However, the physical experience of being a patient with those kinds of levels is a different story. So typically that means you're at high risk for severe OHSS. So Lupron trigger, high protein intake, high fluid intake, cabergoline or bromocriptine, letrozole after the trigger shot. All of these things can help prevent OHSS. So talk to your doctor about that if you're still in cycle right now. Okay, I saw a recent study that said age doesn't affect mitochondrial quality in eggs. Obviously not the DNA though. Thoughts on this? So I do think that age does affect mitochondrial quality in eggs. I think so much so that I'm trying to get people to stop saying advanced maternal age and start saying advanced mitochondrial age, because my patients who are 40, they are not old. They're not advanced age. They're young, they're healthy. I mean, look at the new bachelorettes. I mean, they're this new golden bachelor. I mean, these women are in their 60s and they look like they're in their 30s. Like, I was just flipping through a recent post, kind of like introducing the world to the new bachelorettes, or the women that are on the next show. And I was just looking at them and saying to myself, these women, you know, quote unquote, they look fertile. You know, they look young enough that they could have healthy eggs, and they're in their 60s. So I predict a generation from now, clinics will be seeing, on average, probably 10, 50-year-old patients trying to have even their first baby. So right now, my practice is full of women in their early 40s, and I have many, many patients in their mid 40s, even early 50s, that I think things are going to shift even more, 20 years from now. So let's see, do I have any other questions from you guys? Can blood testing tell me if I'm in perimenopause? And the answer is yes. So day 3 FSH estradiol and an AMH level can tell you. But even if your levels don't necessarily suggest you are, if you're having symptoms, if you're feeling hot flashes, vaginal dryness, super moody, breast tenderness, that could be enough to say that maybe you are, and considering HRT could help you. So even if you're having regular cycles and they're not super irregular, it is still possible that you could be experiencing perimenopausal symptoms. Well, thank you guys. That's all your live questions from today. I really appreciate the time you guys took to spend with me. And go to asktheeggwhisperer.com, ask your questions. You can also join my next IVF class on Monday. You can go to eggwhispererschool.com. And I love, seeing everybody and answering your questions. And I hope you guys have a great rest of your day and week. Thank you, and love you too.